You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is November 14th, 2025. We will be doing our fellow presentations, and today is Journal Club. This is presented by Dr. Cheyenne Sazdar, an Allergy and Immunology Fellow at Children's Mercy Hospital in Kansas City and UMKC.
So I'm Cheyenne. I'm one of the first-year Allergy Immunology Fellows here, and today is November 14th. I'm going to be presenting Journal Club. So the journal article that I've selected for today is Guidelines for Early Food Introduction and Patterns of Food Allergy. This was published October 20, 2025 in the November 2025 pediatrics journal, and it was written by Dr. Stan Gabrzeski, Dr. Jesse Dudley, Dr. Jennifer Farber, Dr. Robert Grunmeyer, Dr. Alexander Fix, Dr. Jonathan Spergel, and Dr. David Hill. And this was at a Children's Hospital of Philadelphia. So background, introduction, and I'll just preface that this is what I'm be doing is going through the journal article and then adding in my own comments as well. But a lot of this information can be referenced directly from the article for further information. So we know that IgE-mediated food allergy is the #1 cause of anaphylaxis in children, and peanut allergy is a common food allergy in children as well. We all know about the LEAP trial, and since that in 2015, that basically showed that infants who were 4 to 11 months of age who had severe atopic dermatitis or egg allergy and who regularly consumed peanuts had an 81% reduction in their risk of developing peanut allergy. So some evidence to show that you could prevent peanut allergy development in these children. And since then, there have been multiple guidelines that have been published. 2015, first being for these high-risk infants with these severe atopic derm and or egg allergy for introduction around 4 to 6 months of age, and then an addendum in 2017 for both high-risk and then the more moderate risk infants to introduce at 6 months of age, and then in 2021 recommending early introduction of peanut, egg, and major allergenic foods by 4 to 6 months of age, regardless of risk factors. Despite these new guidelines, there's been a variable uptake of the guidelines, which makes sense as it takes time for providers, physicians, primary care doctors to change their practices, and but it's important to see, I guess, how has that impacted rates of food allergy, incidence of food allergy. So the question was raised, has rate of clinician-diagnosed IgE-mediated food allergy to peanut or any other food changed since these guidelines? And I think that's an important question to see if we have good answers for and to look further into. So this study was the study design included data from the AAP comparative effectiveness research through collaborative electronic reporting, CER squared database, and this is a HIPAA-limited EHR database of primary care practices throughout the United States. The study focused on 31 practices affiliated with an academic health system in the Mid-Atlantic, and then 17 independently owned private practice, private pediatric offices across the United States. And the time period of the study was from 2012, so this is pre-implementation of the first pre-announcement or publication of the first guidelines, and then it ended at January 31st, 2020. So it was a cohort study. There's 2 cohorts. The first cohort looked at patients entering the study between September 2012 and end of October 2014, so prior to the initial guidelines. So these are pre-guideline patients, and then there's post-guideline patients. The cohort entry between September 2015 and end of August 2017. The first analysis, participants must have entered the primary care before age 1 year, so looking primarily at young infants, and then they were observed minimally 2 years for development of any atopic dermatitis and or an Ig-mediated food allergy. And then there's a second analysis that was done, includes the first analysis, but also a third cohort, which is a post-addendum guidelines, and these were children entry between February 2017 and end of January 2019. And there was a 1-year observation window with this, and then sex, self-reported race, and ethnicity were also included per the EHR documentation. So this is a visual or graphic that basically again shows the study design for the two analyses. One is the pre-cohort guidelines. So again, children entering between September 2012 to 2014. Again, these first set of guidelines were not published at that time. Comparing them with these post-guideline group or cohort. And then there is an additional analysis with a 1-year observation after the addendum guidelines published here in 2017, and is comparing all three. So what was measured? Children with a peanut Ig-mediated food allergy, and then children with one or more Ig-mediated food allergies, and children with or without preceding atopic dermatitis. To call it a diagnosis, for at least the purpose of the study, they looked for a diagnosis code using ICD-9 or ICD-10 or the systemized nomenclature for medicine codes. And they looked for also listing of a food allergy as well. They described it as in the allergy module, and I wasn't really able to specify what is meant by an allergy module. But in different reading, or like throughout the article, I think this really means they're looking for basically a diagnosis code mentioning of the food allergy in the note, I presume, or somewhere else within the documentation, and then a prescription for an epi-auto injector as well. And that it was specified without a pre-specified order, which is also uncertain to me what that exactly means. But I would assume that perhaps maybe that means that there was intention to order it based on the diagnosis. But I think that would be a good question to further clarify with the authors. But so, anyways, these were the three criteria that were used to determine if the patient had a food allergy for the purpose of this study. So it's always good to look to see how many children were included within the study. So in the pre-guideline cohort, about 38,000, post-guideline 36,000, post-addendum guideline 39,000. So close to 40,000, if you round up either of these groups. So quite a number of children were included in the study. What I'd like to first focus in on is this is table 5 from the journal article, and basically it shows the difference in pre-guideline versus post-guideline documentation of food allergies in this first analysis group. So this is the post-2015 guidelines being published. So if we take a look of that, 30, I believe it was like 38 or 35,000 plus patients, 0.92% were found to have a peanut allergy, and this was the number one food allergy in their assessment. And then second food allergy, most common, was egg, and then third was milk, and then so on. Post guidelines, they saw that peanut actually went from the 0.92% to 0.668%, so the incidence decreased. And this was a statistical significance. Additionally, while peanut remained the third ranked food allergy, the incidence the percentage did decrease from 0.44% to 0.296%, which is also shows there's a statistical significance too. So we already see post guidelines there, at least in these in the study, there was a difference pre and post guidelines and a reduction in the peanut allergy. And we'll go to the next. So this is table 6, and this is a distribution of documented food allergens pre-guideline, post-guideline, and post-addendum guideline in 2017. And I know we already we took a look here at the milk or in the pre-guidelines, peanut, egg, milk, and then became egg, peanut, milk. And then if we look at post-addendum, again, we saw a further decrease in the peanut allergy as well, with statistical significance, and also reduction in milk allergy as well in the post-addendum guidelines cohort. Oh, will I go to the next? So this table here looks at the cumulative incidence of IgE-mediated food allergy or atopic dermatitis in the study cohorts, and this is the first analysis. This is just pre-guideline and then post-2015 guideline. So pre-guideline to post-guideline, peanut in all children, peanut food allergy, IgE-mediated food allergy. There was a 27.2% change or decrease, and this was statistically significant. Documentation of all children of at least one or more IgE-mediated food allergy. There was also a decrease in the incidence. Once again, and then if you look at 2 or more food allergies, also a decrease as well. And then if we look at all children, we also saw that atopic dermatitis had also increased. It had increased, not decreased. And then we look at the group of children who had a preceding atopic dermatitis, and among those who had a preceding atopic dermatitis, while there was a decrease in food allergy to peanut observed in the post-guideline period, it was not statistically significant. Additionally, same can be said for the decrease in any food allergy, at least one or more. While there was a decrease, it was not statistically significant in this group who had of children who had preceding atopic dermatitis. And then there was also a not statistically significant increase in children who had preceding atopic dermatitis with 2 or more food IgE-mediated food allergies. Children with preceding egg IgE-mediated food allergy, and looking at the peanut allergy, the peanut allergy incidence in these children, there was a decrease of 41% in the post-guideline era, and that did have a statistical significance. So just taking a look at this, I think probably what sticks out to me the most is, one, there's a decrease, there's an observed decrease in food allergy in all children post-guidelines 2015. And what's also interesting, though, however, is in the children with a preceding atopic dermatitis that I would think as an allergy fellow would I would presume these children would have a higher risk of having developing a food allergy. There was not a statistical significance in the reduction in the peanut and one or more food allergy categories. Okay, and then I apologize. Okay, so this is the cumulative incidence of IG-mediated food allergy or atopic dermatitis in the second analysis. This is a one-year observation post the addendum guidelines. So here, again, looking at all children in terms of peanut allergy, there was a decrease in the post-addendum period as well with statistical significance. It says relative percent change of negative 43%. One or more food allergies, yes, there was also a decrease in the post-addendum. That was statistically significant and so forth. And again, there was a noted increase in atopic dermatitis post-guideline. And post-addendum guideline. In terms of children with preceding atopic dermatitis and food allergy diagnosis for peanut allergy, one or more food allergies or two or more food allergies, the results were not statistically significant. And then in the group of children with a preceding egg allergy, the peanut allergy cumulative incidence did decrease, and it did have a statistical significance. Okay, so this graph or this chart here basically shows what's called an interrupted time series analysis, and basically helps to visualize and also understand a change in the percentage of 2-year-old children who have a food-mediated allergy longitudinally over time, both pre and post the 2015 guidelines, and to take a look at the slope of the slope change as well. So if we look at pre-guidelines, there is this pre-guideline slope showing the percentage of 2-year-olds who have food-mediated IG allergy. And then if we look post-guidelines, there's a downward trend, and this slope is different than the other one. And this does show that post guidelines, there has been a decrease, at least in this study, of observed percentage of 2-year-olds with food allergy. And then this is a Cox proportional hazards modeling showing basically that for the children with a diagnosis of peanut allergy or any IgE-mediated food allergy during the post-guideline or post-addendum period, there was a reduction of the proportion of the children with the food allergy or the peanut-specific food allergy as we move from 0 years of age to 2 years of age. Again, we can see pre and post guidelines. The post guideline is lower than pre and post addendum guideline. The addendum guideline proportion is lower as well. And similarly, we can see the same for any food any food allergy that's IgE mediated. So again, considerations, questions. So this study was not able to assess the impact of guidelines across the entirety of childhood. Reason being, guidelines were released in 2015, and childhood is from 0 to 18 years of age, so enough time has not passed. Also, it's important to note that at least among, we still don't know what the impact of these guidelines are on overall food allergy rates. Per National Health Interview Survey, there was not a remarkable change from 2012 to 2021, so almost 10-year period, in parent-reported food allergies in children less than 18 years old. But however, when we focus in on this younger group of children over that time, at least this study does show in the children that they studied, the charts that they looked at, that there does seem to be a difference from pre and post guideline. This study did use a 16-month gap washout period to adjust for any delayed uptake of the guidelines. I would ask, what is considered an appropriate washout period? And also, other question is, what percentage of the primary care providers of the children in this study in the post-guideline period actually were implementing the guidelines? I didn't see any comment about whether all these primary care providers were implementing implementing the new guidelines. We were just observing in this post-guideline era what are the changes. I feel that if it sounded like there was a mix of private practice, academic institution. I don't know if there were any primary care providers who were residents. I feel that in residency, perhaps in residency programs, I think graduate medical education and trainees are probably are more likely to be exposed to new guidelines. Of course, community providers and physicians are also stay up to date on guidelines. But I'd be curious to know if the results of the study were impacted by anything like this, because I don't know anything other than private practice versus academic hospital or academic health system. What was the demographic of these providers? Also, again, the question comes up, why was there not an associated decrease in food allergy in the patients with the preceding atopic dermatitis post-implementation or post-publication of these guidelines? The article did touch on this question as well, and there's thoughts that maybe potentially with early recognition of atopic dermatitis, perhaps that may have potentially led to potentially maybe there was and this is me extrapolating here, maybe there was more detection of atopic dermatitis just post the guidelines, so we didn't see possibly a decrease in food allergy in those groups, in that group. And then again, this may also go to say that there is a variability in implementation of early introduction practices. So I don't think I can say more than that, but it was an interesting observation. So this study, like all studies, had limitations, and as I've kind of highlighted on some of them, but some important things that were not included in the study include feeding patterns, were not taken into account, time of introduction, frequency of ingestion. These were all unknown. And going back to how the diagnosis was made, there was not any consideration, however, for any food allergy testing results or oral food challenges to confirm whether these food allergy diagnoses, or what we considered patients who had a IgE-mediated food allergy, were they a true food allergy. And then it is unclear, per the authors as well, that if this study is generalizable to other health systems. And then it's also interesting to note that the percent reduction in the study for peanut IgE-mediated food allergy was less than that observed in the LEAP trial. So that That concludes, my summary of the journal.